This is the Jessamine County EMS in service for spinal motion restriction, i.e., the clearance of the cervical spine. These are our objectives. You can pause and read if you like. So, what is the difference between spinal motion restriction or SMR and spinal immobilization? Because there's a paradigm shift from calling it spinal immobilization to spinal motion restriction. Well, drum roll please. While current techniques limit or reduce undesired motion of the spine, they do not provide true spinal immobilization. For this reason, the term spinal motion restriction has gained favor over spinal immobilization, although both terms refer to the same concept. The goal of both is to minimize unwanted movement of the potentially injured spine. So, what evidence do we have for spinal immobilization or spinal motion restriction, if we have any at all? Actually, you may be surprised to find that there is none. There is no evidence that spinal immobilization actually immobilizes the spine. That's why we have shifted from referred to it as spinal immobilization to spinal motion restriction. There's a lot of good data that, allowing ambulatory patients to self extricate with a cervical collar actually results in less cervical spine motion than if we force them into that position using a backboard. Now, so we're not immobilizing the spine. It's a misnomer because you can't actually fully immobilize the spine, so we shouldn't use that terminology. But there is evidence that patients have deteriorated after the reported mishandling by EMS after an occult spinal cord injury, and that they attribute this the injury to the spine from mishandling by EMS, surprisingly or not surprisingly, but there is a interesting study that compared patients in Malaysia to some patients that were transported in EMS. Now, in Malaysia, spinal mobilization or spinal motion restriction is not a thing. So they don't actually immobilize patients. So if we're looking for a patient population to compare to ours, then this is the best that you can get because it's not a thing in Malaysia. And if we compare the numbers of patients with disability in the U.S. to the patients with disability to the unimmobilized patients in the U.S., we can actually kind of extrapolate from that if spinal motion restriction actually does anything or not. So if you compare the rate of that had significant disability um, that were immobilized in the United States here, 21% had significant disability compared to 11% that were immobilized and or not immobilized in Malaysia. So clearly, something about spinal immobilization causes more disability. And the theory is that some patients present with asymptomatic but clinically important spinal injuries that aren't picked up on EMS assessment, such as this here and there. So, but in reality, those reports are case reports and they're dubious, and a lot of people want to attribute it to mishandling by EMS. Um, but the most likely explanation for these patients is either A, they did have some significant clinical assessment finding where they actually did need a spinal motion restriction and didn't receive it, or B, the patient actually did not have any pain, which would be extremely rare, if not impossible. The patient did not have any pain, and it had nothing to do with how EMS handled the patient, which is most likely, but that the disease had just progressed. So the spinal cord can swell just like anything else, and it can become ischemic and get worse with time. But like with everything they like to blame EMS. So if we look at the number needed to treat for benefiting patients with penetrating injuries, so this was a major study conducted by the Eastern Association for the Surgery of Trauma, which is a major trauma organization. They looked at about 155,000 patients. What they found was that no one benefit, and you had to treat 10 patients to harm one. So that's a significant number of harm. And they found that their recommendation was that the harm is worse than the benefits, and that spinal mobilization is not recommended for routine use in penetrating trauma. All right. So should we dismiss spinal motion restriction entirely? Why are we even concerned about it? And I think there are a lot of educated people that say that since there's literally no evidence except a few case reports of patients who may or may not had a clinically silent severe spinal cord injury, they say, well, let's just do away with it altogether. But we're not going to do that, right? Because there are some who think that those that are touting getting rid of any form of spinal motion restriction or spinal mobilization are heretics, and that there are some quote unquote experts who will argue the fact that we should be immobilizing. So we are still taking precautions. We are still taking spinal pain and associated complaints very serious, and we're still managing those patients with some form of spinal precaution. So it does not mean that we're not taking it serious and we're not taking these special precautions in high risk patients. So this is what our protocol is. And here are the indications. So this is how you now clear patients from spinal motion restriction. And we'll go over what spinal motion restriction is and how it's achieved. But first, you look for any focal deficit. If they don't have any focal deficit, then are they altered? If they're not altered, then are they intoxicated? If they're not intoxicated, do they have a distracting injury? Now, depending on who you ask, you'll get different responses on what a distracting injury is. The classical description of a distracting injury is a patient with a femur fracture. However, some patients with femur fractures can be completely lucid and actually concentrate on the neck or on your palpation of the neck to determine if pain is present. Conversely, some patients may have a fractured finger, not a femur, but a finger, and be hysterical and screaming in pain, and that could be a distracting injury. Then we want to perform a spinal exam and see if they have any point tenderness over the spinous process or pain with neck motion. We generally forget this segment, but when we're performing our spinal exam, we actually want to palpate. And I think a lot of people kind of just rub their hand or rub their fingers over the cervical spine. You actually want to palpate. You want to palpate the spinous process, and you want to feel for any deformities or step-offs. And you specifically want to know if the patient has pain. If they have pain anywhere on their neck, even if it's lateral and not in the middle, we should still probably take spinal precautions. So if the answer is no to any of these, then spinal motion restriction is not required. Now, if yes to any of these, we have to describe what spinal motion restriction is. Spinal motion restriction is you apply a cervical collar and you lay the patient comfortably on the stretcher. Okay? You want to restrict spinal movement by having the patient lay flat and secured firmly to the stretcher. And then you follow the spinal precautions procedure. So if the patient's ambulatory, you can actually bring the stretcher to the patient. You assist them. You don't force them into an uncomfortable position, but you assist them onto the stretcher with minimal movement, and you secure them firmly. If the patient is not ambulatory, you use a long spine board or a scoop stretcher, or maybe in the future we will get vacuum mattresses. But you extricate them or move them with a device. Then once they have been moved, you can remove them from that device. And so the technique, you can use a log roll or a straddle and slide, but a straddle and slide is actually preferred over a log roll. There is less movement with the cervical spine compared to a log roll. As always, you got to recognize that your exam may change. If a paramedic's available, we want the paramedic performing the assessment. If a paramedic's not available, then it is the EMTs can perform this assessment and place the patient in spinal motion restriction precautions, or they can clear them. So a lot of people would say, why are we even taking the risk? Does it really hurt anybody to immobilize them for just a 20-minute transport? What harm are we doing? There is real harm with immobilizing every patient, especially when they don't need it, and especially if they have penetrating trauma. And we owe it to our patients to do the most harm, to do the most good and the least amount of harm. For example, spinal immobilization, even if just for short periods, can cause pressure ulcers. It changes your physical exam. So, in a patient who wasn't previously complaining of neck pain, if we fully immobilize them, they may start complaining of neck pain, which could lead to unnecessary imaging at the hospital. It worsens pulmonary function. So patients that have poor pulmonary reserves, your COPD patients or congestive heart failure patients that you wouldn't want to lay flat, it could significantly hurt them. It increases intracranial pressure. So if you have a patient with a potential head injury, part of the treatment for a patient with increased intracranial pressure is elevating the head of the bed to 30 degrees. That's very difficult to do if they are on a long spine board. Additionally, cervical collars can actually impede venous return. And you want to elevate the head of the bed to allow the drainage of venous return, but if the cervical collar is really tight and is impinging upon the jugular veins, then it could actually worsen intracranial pressure. And last but not least, and this is a major one, it increases the difficulty of airway management. So it makes it more difficult to properly position the patient to get them on the right plane for you to be able to successfully intubate them. And if you can't ventilate, if you can't oxygenate, and you can't adequately manage the airway of a patient, you're probably going to do more harm if there was a spinal cord injury by allowing the patient to become hypoxic, because the spinal cord, just like any other organ in the body, needs good perfusion and needs good oxygenation. So if you weren't following any of that, here's the too long didn't read version. There are significant risks with immobilizing patients. I want to stress, we are still immobilizing high-risk patients. Not necessarily high-risk patients based on the mechanism alone, but based on good assessment findings. We don't live in Malaysia, unfortunately, so we're still immobilizing them because the United States is still a highly litigious place. Most of the time, the benefit does not outweigh the risk. However, we also don't want to become a case report. It's contraindicated in penetrating trauma, and you remember the definition, but don't forget to document. If patient refuse, have them sign a diversion form. And you should always document your spinal assessment. If there are pertinent findings, document in the narrative. Otherwise, use the spinal assessment form. Here's a special note about spinal motion restriction in children. So, the National Association of EMS Physicians came out a few years ago with a position paper on spinal motion restriction. There is not great studies on pediatric spinal cord injuries. But based on the studies that we do have, this is what they recommend. If the patient has any of these, they want us to perform spinal motion restriction. The risk or the rate of contiguous multi-level injury in children is extremely low. We need to recognize that we also have to minimize the time on backboards with consideration for use of a vacuum mattress. And we may, in the future, not anytime in the near future, but in the future, be getting vacuum mattresses. But you also have to pad. You specifically, in kids, need to remember to pad under the shoulders so that you don't have excessive cervical spine flexion, right? Because if the shoulders, because the head is, the occiput is large relative to the rest of the body, and the head could actually be flexed forward in children. So some have asked during the protocol review that we explain using a car seat, okay? Because we prefer the ACR4. Here's the problem. If you're really concerned about a spinal cord injury, you wouldn't want to move that kid from the car seat. But if they do have a potential spinal cord injury, then there's a good chance that they have other significant injuries, and you would need to perform a detailed assessment, and you can't do that unless you take the kid out of the car seat. Folks have valid concerns about the safety of transporting children in car seats, and we're not supposed to use the car seat if it was involved in an accident. But if you're legitimately concerned that they have a spinal cord injury, that you can make something worse by moving the kid from the seat, then you have to weigh the risk versus the benefit, or the benefit versus the risk. Children in general are difficult to fully immobilize, and if we try to put a cervical collar on them, then they may turn their head more, they may pull at it, and that's your documentation, right? You just have to document why you did what you did or why you did not do something that you were supposed to do. Clinical judgment rules all, and there's just not great guidance on immobilizing children. So I understand you may have more questions than answers. Hopefully we will try to clear those up soon in the future. And if you ever have any questions, feel free to contact me. Bye.